ARCHway Institute. As a peer support, I work with ComTree on the Epic Outreach project. I'm the lead coach for that. And, I've been a manager of Recovery House for an extended period of time. And, I wanted this today to kind of be about, my recovery story, how substance use took shape, and what recovery looks like, what we're doing now. Also kind of added into that, we were going to talk about, the effects that COVID-19 has had on the recovery community at large. And so, I think today is going to be really cool. If you have any questions, throw them into the chat and we can just go through them as we go. So like I said, I'm in long-term recovery. Looking back at how substance use got started for me, I was roughly 14, 15 years old when I started getting introduced to substances. What that looked like initially was primarily alcohol and marijuana. It kind of began as like a social thing, but being able to kind of evaluate the situation now, what I saw is that I was treating untreated mental health, right? I mean, we're talking about things like, pretty severe depression, OCD that was really bad. And I wasn't able to recognize that this was mental health that was going on with me at a young age, right? And so, but what I did notice was that when I was using alcohol, when I was using marijuana, the symptoms that I was experiencing started to go down, right? I felt a level of relief, felt a level of comfort, less anxiety, less OCD, stuff like that, right? And so consciously and subconsciously, once I realized, that wasn't out, I took it. I utilized substances to help treat these mental health symptoms that I had going on at the time. One of the ways that I kind of try to express that is, people, you, me, whoever, are not going to live either in like physical or emotional pain for extended periods of time, right? Like I will find a solution. Unfortunately, the solution that I found at the time was not a productive one, even though, it was effective. I say a lot of that to kind of get into talking about prevention programs, right? So NCADA has a prevention program. It's in over 200 schools. It's served over 60,000 kids, and one of the things that I think is critical about this is one, it seeks to alleviate the stigma surrounding seeking help for mental health and substance use, right? And so, nobody looks at someone twice for going to the doctor for a sprained ankle, right? But there is still legitimate social stigma in our society around seeking help for mental health and substance use, and when I look at, me as a youth, I saw that I felt, isolated when I wasn't. I felt misunderstood. I felt a lot of things that even though they weren't 100% justifiable, I think a lot of that is related to stigma around mental health and substance use and not asking for help, not seeking out help, And so looking at prevention, I think that, if we would have had effective prevention programs in my schools as a young person growing up, I think a lot of my substance use going forward could have been, mitigated or alleviated if I had better understood, what mental health is, what I was suffering from was that, and that it is treatable. Like there are solutions that a person can utilize, but unfortunately at the time I was absolutely unaware, and I think it kind of leads into my recovery story a little bit, going forward, getting out of high school, starting to go to college, stuff like that. I started getting introduced to more serious substances, right? Start looking at, I was introduced to benzodiazepines. I was introduced to opiates in the form of, prescription opiates. And, as my use continued, as it got heavier, things really started to get out of control. That led to, severe withdrawal symptoms. It led to use going from prescription opiates to, illicit heroin. And, when we do a lot of these educational talks, when we do some of this stuff, at the time, believe it or not, it seemed like an absolutely rational thought process to go from using prescription opiates to using illicit heroin, right? Just from a standpoint of availability and price, right? But once that happened, things started to get out of control for me pretty quickly, and as things started to progress, I realized that what I was doing was not productive. I realized that it was detrimental to my health, detrimental to my relationships, detrimental to, all the things that I wanted to achieve in life, but I was not aware that, treatment was really available, that services were available to individuals who were struggling. I wasn't aware of social support, in the form of, I wasn't aware of substance use treatment, mental health treatment, all these things. So what that led to was me attempting to stop using on my own, and could go on for a long time about that, but let's just say it was unsuccessful, right? So, in 2013, I went to Centerpoint Hospital. I went to their detox program, and then I went to their 21-day inpatient. While I was there, I saw a physician, and I was introduced to buprenorphine in the form of Suboxone. I was prescribed mental health medications, and upon discharge from there, I did well for a few months until I started to, seek out drugs and alcohol again. That took form in alcohol, prescription benzodiazepines, recreational drugs like cocaine. Really, the only thing I wasn't doing was, illicit opiates. Just to kind of fast forward a little bit, that kind of culminated in, I was driving a motor vehicle, had a seizure, and, crashed a car. And this is serious stuff. I could have killed myself. I could have killed someone else, and I ended up in the hospital as a result of that. Physicians at the hospital said it was related to, benzodiazepine withdrawal, cocaine use, etc. And while I was there, I had family members that were willing to, try to help me out, try to find treatment services available. So in 2014, I went to ARCHway's inpatient location, Mira, and that's where my recovery story really begins, right? I was introduced to, it was my first introduction to Vivitrol. It was my first introduction to recovery housing, and it was my first introduction to, peer supports in the field. While I was at Mira's inpatient, I wanted to touch on peer support really quickly. There were two peer support specialists that were working at ARCHway while I was there. It was John Stuckey and Dave Allmiller, right? And these two guys, brought a level of truth into that room with me, that really made me reevaluate. They pointed out flaws in my thinking, the fact that I needed to take accountability for my life, for my recovery, for my choices, if I wanted to have, the better life that I said I wanted to have. And that was really the first time that the effectiveness of peer support, first time I noticed that. And it was the first time I was like, I really felt like understood and connected at, at a treatment provider. While I was at that stay in inpatient, I was introduced, like I said, to Vivitrol. Vivitrol is a non-habit forming medication that I utilized for years upon discharge. Vivitrol was critical for me in multiple categories, right? But, for one, Vivitrol facilitated, it's a 28-day injection, excuse me, sorry. And what that did for me is it alleviated the responsibility of making that right choice every single day, right? And through that, not only did it alleviate cravings, but it shifted my mindset in a way, think about how to describe this, but a more productive mindset. You can't use next week. You can't use the week after. Why don't you start focusing on what you can do to make your life better, to make your situation better, right? And the effect that had on me was, I was able to start focusing on my recovery program, what I could do, and even through early recovery, going on to, maintaining long-term recovery, I continued to utilize Vivitrol. One, to alleviate opioid cravings. Two, it was effective in alleviating alcohol cravings, and it really provided that added layer of protection for my recovery going forward that, I attribute a lot of my success in recovery to that. The other thing that happened during that inpatient stay was I was introduced to recovery housing, right? And, the two peers that were working at ARCHway while I was there was John Stuckey and Dave Allmiller, and these two guys were managing recovery housing as well. So in early November 2014, I moved into recovery house in St. Louis. What recovery housing really did for me was, one, it facilitated an immediate healthy social support network, whether it be through the peers in housing, whether it be through, the other residents there, but it provided that social support network. It provided a level of accountability, but it was a place where, for the first time, recovery was modeled in a fashion that, appeared attractive to me. I hadn't seen recovery look like that, at treatment providers that I'd been at. I hadn't seen it at outside meetings I had been at. It was the first time, I noticed, like, wow, these guys really are happy. These guys really are successful in recovery. Like, these guys are doing stuff they want to do, and once I saw that, and could really see that it was real, I began to pursue it, and through housing, through peers, that's what really got me to, like, buy into the recovery process, and seek out a better life.
Colton, this is Stacy.
Hey.
I think let me let you take a breath for a minute. Somebody asked the question in the chat, and I think you were actually answering this. Why do you think the peers had such a different impact? And I don't think you said this specifically, but it sounds like a part of what made that effective and what made you buy into it was that they had that lived experience. Am I on the right track with that?
Yeah, it's absolutely on the right track. Peers being there, a lot of times they kind of bridge the gap between, a lot of the other providers that was there, whether it be physicians, social workers, case managers, group facilitators, and the peers, for one, like I said, they modeled recovery and got me to buy into the process. But, what I've seen peers also be is, a really critical component to treatment teams, right? Because, a lot of times in the substance use and mental health field, you hear clientele say, you don't know what I'm going through. You don't understand where I'm at, but a peer can walk into that room and say, I do understand where you're at and I do understand what you're going through, but I can also, help you find the solution. I can also help you find a way out. And they kind of legitimize the other members of the treatment team to the clientele that they're serving to kind of get them to buy into the process. So I think that's a huge component that peers play. Did we have other questions coming up through the chat?
Not right now.
All right.
Thank you.
Yeah, no problem. But through recovery housing, I saw the value of peers, like we were saying, and, it became pretty evident to me that that was something that I wanted to do as well. The process starting out for that was, I was given the opportunity to become a manager at Recovery House, and, being a manager at Recovery House was not a paid position, but it was one of the more like impactful responsibilities that had been given to me up into that time, just because, I know when I came into recovery housing, I was like pretty broken and not in a good place in life, and these guys, like showed me a way for a better life, and so when that opportunity was presented to me, there was nothing I could think of that would be, better for me to utilize my time, energy, skills, resources to than that, and I tried to tell the guys, I told the two guys who were managing the recovery house at the time, I was like, guys, like, I can't pay you back for this, like, how do you monetize like a human life, And John was like, Colton, like, I'm good. All right. Pass it on to the next guy. Pass it on to another person, and that statement, that moment had like a profound impact on, not just the way I started to view recovery, but on the way I viewed a way in which I wanted to live, a lot of times in active substance use, everything has a price. Everything has a price. And getting into recovery and meeting guys like John, meeting guys like Dave, meeting peers in the field, who were in it to, strictly to help another person, I hadn't met many people like that. And so the opportunity to give back what had been freely given to me in that process was, for sure a no-brainer, and so through that process of becoming a manager at Recovery House, I was, given the opportunity to enter into the, sorry, I think we have a question coming in. Good.
Yeah, Colton. Oh, sorry, Colton. I wasn't sure if you wanted me to read it. Yeah, there's another question in the chat box. What was the most important thing for you in the first hours or days at Recovery House? And what was the most important things you passed on as a manager?
I think in the first, hours and days at Recovery House, I think the first thing that I noticed was the the sense of camaraderie there and the sense of, support that those peers and those residents brought to the table. A lot of times when I tell my recovery story at Recovery House, sometimes it's as simple as, I showed up to a recovery house and I didn't have any food, and a guy that I had met once when I walked in the door was like, "Hey man, come in here, split this frozen pizza with me," and that's not an expensive thing, but to have someone you don't know, just kind of try to share with you what little they had, was pretty impactful. And that sense of camaraderie, I think, is something that stayed with me throughout my years at Recovery House, and something that, I think peers really bring to the field. I hope that the most important thing I passed on as a manager at Recovery House was to try to instill in the people that came up under me, that mindset of keep passing it on. I've had people tell me before, "Colton, I can't pay you back for some of the things you've done for me." And I said the same exact thing that John said to me. So I would hope that if I pass anything on from my time at Recovery House, it would be, the mindset and the, recovery process of, pass that on to the next person, keep that camaraderie, that brotherhood, and that recovery principle of, passing it on to the next person. And through becoming a manager at Recovery House, I was presented with the opportunity to, get into the certified peer specialist class. Going through that class kind of introduced me to, it introduced me to a lot of new principles of, being a peer in the field. Recovery House, the ARCHway Institute, really kind of built me up. They educated me on, what recovery looks like. I built my recovery program around that and MAT, and then through going through the credentialing class, I got an entry-level job in the treatment field, and that's where I was first kind of groomed in a clinical setting, right? Whether it be, providing direct services, whether it be, group facilitation, navigating EMRs, all the things you start to learn as you get introduced to the treatment field, I learned there, and through that job, through ARCA, through Recovery House, through ARCHway, I was presented with an opportunity to work on the EPIC outreach project. The EPIC outreach project, operates in the eastern region of Missouri. It's facilitated by peers. And what we do is, we go to emergency departments, behavioral health centers, and medical floors, for people struggling with OUD, and, being able to, intervene in people's, most critical moments, whether it be right following an overdose, seeking treatment services for the first time, and EPIC, operates at BJC, SSM, and Mercy hospitals in the eastern region of Missouri. We can connect people to, next day treatment services, next day access to MAT, and I talk about this because, it's a principle that we've talked about, at ARCHway and with other organizations as well, is that, for the first time, we can provide next day access to care, next day access to life-saving treatment, for individuals who are uninsured or underinsured, and that's where, I think not just through EPIC, but, in the treatment, world as a whole, I think that's an area where, peer support specialists, ARCHway, NCADA really play a critical role, right? Because, peers can not only identify the needs, but can connect people to like quality and appropriate care, right? Because, you have treatment providers, you have housing agencies, you have medication providers, and without peers, without organizations like ARCHway, people are not being connected effectively, right? And so, being able to utilize peer supports, through EPIC, through ARCHway, through NCADA, and being able to connect people to life-saving care, is something that I've seen that's, really given me a lot of purpose, and a lot of, it's one of the things I'm, most passionate about in this field.
So, Colton, this is Stacy again. I'll let you take another breath and a drink of water. I think this is a good time for this next question. So what does this process look like when someone does not want to go to treatment, when they're not ready? How does that maybe change the equation with peer specialists and all these things that you mentioned that were helpful to you and to others?
Yeah. I think that's a position where peers can play a unique and critical role, right? Because a lot of times, peers can pretty effectively kind of motivate individuals towards change, whether it be sharing their recovery story and some of the things they went to. But one of the things that I usually, try to express when I explain EPIC is that, peers can create a rapport, with a client or somebody in early recovery in 30 seconds that might take, someone else 30 days, right? And so being able to facilitate that pretty immediate rapport and then help that individual to move in the direction to motivate change and to maybe seek out a better life. And that's, that legitimately happened to me as I was telling my recovery story earlier, but those peers really did, make me look at, where my life was at now, taking accountability for that. And they were really able to motivate change within my mindset to seek out recovery. And that's a really good question, Jenny. Thank you for asking that. But I think peers have a very unique role in being able to, create rapport and motivate change with the clientele that we serve, right? While we're on the Thank you, guys. Less serious question. What do you do for recreation now? Well, with the current state of affairs with COVID, I have been, there's been a lot of TV. There's been a lot of, I'm just going into COVID, but I like to, there's been a lot of playing golf. There's been, really trying to work within the recovery community to advocate for peers. And, between EPIC and ARCHway and NCADA, I've found a way to kind of merge what I do for work and what I do for fun, and so obviously there's always a work-life balance in there, but especially with COVID, we've been inside a lot. Me and my girlfriend have been going through some Netflix and some Hulu and trying to work at the same time, but we've been making it work. I think it's about talking about having fun and what do you do for recreation. For me, it's a lot about, just finding that healthy work-life balance, work-life recovery balance that that brings you, a healthy lifestyle. Oh, and then Jennifer, thank you for that comment. Talking about peers and the effect that they have, on individuals in recovery and on the treatment teams that they're a part of, that's usually where I get into my conversation about, where EPIC, where the ARCHway Institute, where NCADA, and where peers really play, a critical role. Being able to partner with organizations like NCADA and SLU has, given me the opportunity to not just advocate for the clients that we serve, but to advocate for the peer movement as a whole, right? I know, and a lot of people on this call, know the inherent value that peers bring to the field, to the treatment teams they're a part of, to the outreach programs they facilitate, and to the clients that they serve, right? But the reality is that the peer movement, it currently is not sustainable, right? It's not reimbursable by private insurance policies, and a lot of times, I've seen the hiring and firing of peers happen with the ebb and flow of grant funding, right? And so, advocating for evidence-based research, advocating for the sustainability of the peer movement itself is something that, the ARCHway Institute and that the MoPros Coalition has really pushed for, right? And to, get on my talk a little bit about ARCHway and a little bit about the MoPros Coalition, MoPros is a coalition of peers that's, objective is to, advocate for peers, advocate for the sustainability of peers and peers looking out for peers, but also to advocate for the clientele that we serve, right? Whether it be, access to treatment, access to housing, providing client-centered long-term care, right? Informed consent on their treatment plans, equal access to all medications, being able to advocate for not only peers, but the clientele that we serve is critical. Like you look at my recovery story alone, right? Fortunately, when I was in the hospital, I had family members that were willing to look out for me and work to connect me to care, right? But if they hadn't made those phone calls and had, $500 to get me in the door, a lot of times the difference between recovery and death is seriously like $500, right? And so, like I'm one person who's trying to like live as an example of this thing and live as an example of recovery, right? But, there's hundreds and thousands of other people seeking help that are probably not getting presented with the same opportunities that I was presented with, right? And so having organizations like ARCHway, NCADA, the MoPros Coalition, advocating for peers, advocating for client-centered care, is critical to be able to facilitate the outcomes that we all want to see, right? Like, this stuff does not happen in a vacuum, right? Like this happens in our communities. Me, myself, your family members, your friends, their kids, whatever, are the people who are struggling. So to be able to advocate for this care is critical to not only the individuals that we're talking about seeking help, but the health of their families, their communities as a whole gets impacted by this thing. Thank you, Jennifer. I hope that some of what I shared today through my recovery story was productive. I hope that, it was able to shine a light on, what was effective for my recovery and what I've seen be effective for, hundreds and hundreds of other people's recovery, through access to MAT, through access to transitional housing, access to peer support, and kind of the things that I was able to, build my recovery program around.
So Colton, this is Stacy. You're getting a large amount of very positive feedback at the moment. I did have somebody ask the question. They asked to please say the name of that program again. So I'm not exactly sure which of those programs.
Let's just roll through them really quick. So the EPIC Outreach Project is engaging patients in care coordination. It operates in the eastern region of Missouri, and it provides outreach services and connection to treatment services for people struggling with OUD. I hope that clarified it. It got written in the comments.
Yeah, I think so.
And hopefully, keep rolling in questions as you get them. But, I kind of did want to get into, some of the positive and negative effects that we've seen COVID-19 have on the, recovery community and recovery treatment. I would, let's start with some positives. It's not all bad all the time, so let's start with some positives. I think a lot of, things in the treatment field were moving towards, in a telehealth direction anyway, and COVID has kind of forced our hands to be able to provide access to care through telehealth services, and so, while there's pros and cons to that, we've seen, treatment locally and, nationwide. I know a lot of them have actually seen increased attendance to treatment appointments and follow-up appointments due to being able to do so via telehealth, right? And so, it highlights problems like, transportation can be a huge barrier to access to treatment, especially in more rural communities, but in the positive light of that, it's seen increased attendance and access to care through telehealth, and to kind of having to do, things via telehealth in a more, personalized manner. I think it's led to, more individualized treatment plans and more individualized, programs of recovery and programs of care. Obviously, if you guys have been, looking at some of these things in the recovery community, you've seen, red tape get cut in regard to prescribing guidelines and in-person, visit requirements to facilitate induction on buprenorphine. And that's been able to facilitate, access to care in a way that has, hasn't been seen before with access to Suboxone, right? And so, I was reading an article today where, ARCHway is able to provide, street outreach and street access to care for individuals who are, struggling with homelessness and also with OUD, to be able to provide access to care, for individuals in new situations. With all these positives, you do come across some negatives as well, with,
Colton, sorry. Before you go over into the negatives, and this is a comment from me actually, about the telehealth. Something I was reading too. Another benefit that we're seeing is not just the reduction in red tape, but it allows the provider to see what the person's living experience is like. It kind of invites the provider into that person's life versus the patient or the person seeking treatment coming into the provider's office, which is this very controlled environment. And so it's really improving providers' understandings of what their clients are experiencing. So I wasn't sure if maybe you wanted to speak a little on that.
I mean, yeah, absolutely. I think, and that equates to not just providers who are prescribing, but there's been case managers and peers who have been providing, through the computer, services as well. And so I think, you did highlight, a positive of being able to see, clientele in their natural environment and kind of be able to make recommendations through, what they were able to observe there. I saw Corey had a question, curious, do you think these changes will carry over once things begin to open back up? I don't have, I don't know for certain, but there are certainly parts of what we're seeing now that I would like to see, carry over from COVID. And I think that's where we can, try to keep the good and cut the bad in relation to this. But I think we've seen, opening up access to care and kind of what providing, telehealth has been able to do and what, cutting some of the red tape along with access to care, has done to increased attendance and done to access to resources. And so I would hope that, we can collect data on that and be able to make a solid argument on why we should be able to keep some of the things that are going well through this.
And Colton, I know I interrupted right before you were about to start listing some negatives. So heading back that direction, we did get somebody submitting a question to us that I think, starts to address this. But they're asking, with stimulus checks being distributed, has there been a concern of increase in ODs and relapse? So I'm that people are going to use the money they're getting from their stimulus checks to spend on substances.
Yeah, I mean, anytime someone gets exposed or gets access to large sums of money, especially in early recovery, you look at the potential for relapse there. Between recovery housing and the treatment providers that I work with, I know that the peers in housing and the peers in the treatment field have really been working with the people they're serving to create, I don't want to say financial planning, but create, a plan for how they can either save that money, how they can spend it responsibly, and what they can do, to mitigate relapse, have relapse prevention plans in place, so when they do get access to that money, they can utilize it in a healthy way, to build their recovery instead of to lead to a relapse. But yeah, that's always a concern when, access to money becomes prevalent. Yeah. We were just talking about the finance side of that and talking about, access to money, but, access to money, you still need access to the substances that we're talking about, and due to COVID, I think one of the things that we've seen or that I've been reading about is that, illicit drugs have been a little bit harder to obtain just due to, the fact that they've been it's been more difficult to produce them and more difficult to traffic them, right? And so that is a trickle down to, street access. And so, not only is the money part a factor, but as, supply goes down, price typically goes up, right? So people oftentimes might have a hard time supporting the same habit that they had before COVID, and I think that's where, we have to look at, increasing access to care and access to MAT, but I think through doing that, you see a natural progression of, diversion of medications that tends to happen as well. I would kind of list that under the negative comment, but, you're going to see as, illicit supply decreases, price will go up, and, diversion of medication will happen.
If somebody's pointing out too that they also know people who have used their money from stimulus checks to finally access treatment.
Yeah, absolutely. I was on a call, 2 nights ago where there was an individual who was able to spend their stimulus money on, access to recovery housing. And I mean, that's it's a really cool story, and so I think trying to balance all this stuff out and get like, you know, how to say this, but like, it's not just about, you know, being able to tell a story and being able to highlight the positives and the negatives, you know, but being able to really create like a coherent and appropriate, you know, guidelines out of this so that, you know, when the restrictions around COVID do subside, that we can advocate, you know, for what has gone well through this and what hasn't. And hopefully that would give us a more tailored approach, be able to provide really like more client-centered care and access to resources, you know. That was the last question that came in. Yeah, that's a good point. You know, we talk about medication diversion, you know, but you know, something else I think would be good to highlight, you know, is I know that, you know, access to Narcan and Narcan distribution has been, you know, a little bit more difficult, if only through, you know, I'm a recovery coach on the EPIC Outreach Project, and we've been, you know, providing phone outreaches, and soon we'll be, you know, able to provide virtual outreaches to individuals. But, you know, in a situation where previously you met with everybody face to face and you could do, you know, Narcan distribution with individuals, now it's, you know, it's become a little bit more difficult to, whether it's meeting that person in the community to be able to provide access to Narcan. But, you know, I know NCADA is going out and being able to provide Narcan to individuals, you know, but with less, you know, face-to-face interaction. I think, you know, real negative's been really having to push hard to be able to provide individuals with, you know, access to Narcan. You know, looking at another drawback, we just said a lot of positives in relation to, you know, being able to provide virtual access to care, virtual access to recovery, you know, all the way down to social support groups that, you know, will do groups through, you know, Zoom or Teams or whatever. But, you know, to be able to access that, you have to have access to technology, right? And so, you know, for individuals, especially in early recovery or seeking help for the first time, sometimes, you know, access to a smartphone or access to tech can be a barrier, you know, to accessing that care. Sorry, guys, I was trying to see if any comments came in. You know, we talked about, you know, the positives along with, you know, access to tech. But one of the things, you know, that we've seen, you know, as a result of people are not meeting in person, people are not being able to attend group, you know, and that I think sometimes can lead to, you know, a lack of accountability. You know, doing virtual, I think for, you know, even staff members has proven difficult, but when you're providing, you know, virtual social support, especially, you know, for individuals in early recovery, I think some of that social connection kind of goes away. You know, that ability to provide, you know, direct accountability kind of goes away. And, you know, just being able for, you know, for staff members to kind of track behavioral patterns, to be able to provide that accountability sometimes gets lessened when you lose that face-to-face contact, that ability to be there with another person. You know, I've seen situations also, you know, where as a result of COVID, as a result of, you know, the financial strain that's put on individuals, you know, where people's treatment plans have been changed, you know, as a result of, you know, funding and money. You know, I've seen individuals who, you know, were transitioned from, you know, Vivitrol to naltrexone, you know, as a result of funding issues and, you know, situations similar to that, you know, with other medications. But, you know, having those drastic changes happen to their MAT program or happen to their recovery program at large, you know, can be really problematic. And that's a huge drawback as a result of COVID. And lastly, bring up, staff cuts. Cutting staff members has a negative impact on, the ability for individuals to provide quality care. Very fortunately, the organizations that, that I partner with have not had to cut any staff, and they've been able to ramp up and be able to provide the services that are necessary to, the individuals that they serve. But, it's a real thing, and it's something that we've seen happen, in the recovery field as a result of COVID. And I think that's a major drawback. If you guys want to open it up to questions, whether you guys want to ask them verbally or continue to add them to the chat, either one is fine with me. But we can go ahead and open it up.
Yeah, Colton, this is Stacy again. It sounds like we're starting to wrap up, but there is another question in our Q&A. Someone says, I'm having trouble with some of my clients. When talking about drug use and the negatives, they will turn it around and tell me that, sounds like, I don't know what it's like to be miserable and how good drugs make the situation better. I don't know how to counter that as a peer. I'm just trying to build the best relationship I can with them. Any suggestions?
Yeah. So that's a really good question. So, even individuals who are suffering like really severe consequences of their substance use, those substances still play like a critical component in their lifestyle and their ability to, cope with the problems that they're having. When you talk about, even out of my story, as detrimental as substance use was to me, it still served a multitude of purposes, whether it be, treating untreated mental health, whether it be like coping with grief, whether it be, a lot of problems. As detrimental as it was, utilizing substances still played numerous, what I considered positive roles in my lifestyle, and I think that's where, when you're speaking with that client or when you're intervening in these situations, it's like, I understand, that substances do play, a role in your life. But what I'm trying to do is trying to not just get you to stop using substances, but get you to a quality of life that you want to live without substances, right? And so working with them through that process of, whether it be alleviating withdrawal symptoms, connecting them with recovery resources, and getting them to a place where they can live the quality of life they want to have absent of substances. I hope I did a decent job explaining that, but that substance use still does play like a critical role in their ability to live and cope with life. So understand that they are going through a loss, when they give up substance use, even though you might not see it that way. And that's where you got to motivate the change to say, I will help you achieve a quality of life that you want to live absent of substance use.
And Colton, maybe this is off, so tell me if I am, but as you were speaking, something that reminded me too of is, and what we talk about at NCADA at our core is that when we talk in any context, we're never framing it in terms of good or bad or right or wrong, but we can't talk about it in ways, what is healthy versus maybe what is less healthy, what is risky, what is less risky.
Yeah.
That's what it reminded me of when you were really talking about acknowledging that, like, we can't tell them that they're wrong if they're saying that this substance is what brings them relief. Yeah.
And you probably said that a little bit more eloquently than I did, and probably with a little bit, less rough around the edges. But yeah, I'm glad you got in, and I'm glad you said that, because it absolutely does.
So Colton, there's still just some really great positive comments rolling in, so we'll have to make sure to save this chat box so you're able to see all of them. And I think we can definitely stay on for a few minutes longer. But I wanted to add another comment too, to kind of bring things full circle and just talk about the appreciation that we have and also should continue to have for peer specialists. Something I remember very clearly was actually at the ARCHway dinner, which for those of you who are on the webinar, if you haven't been, it's a fantastic event. And one of the SLU physicians was speaking, and she pointed to evidence that's out there, what we're seeing with data, that it is not the intervention that is important. It is more important when it is the person who's delivering the intervention that sometimes is most important. And that really stuck with me, and that just makes me really think that aligns so much with what peer specialists are doing, and it really makes the case to continue this type of this sort of program and this service.
Yeah, that was well said. Yeah.
Did you want to add anything to that, or?
I mean, I think you hit the nail on the head, and I've said that to many people, whether I'm dealing with caregivers or, other individuals on treatment teams, is like, it's oftentimes not the message that you're conveying, it's who it's coming from, whether it be coming from a loved one or from, someone that they think doesn't quite understand their situation quite as well. And yeah, I think that's where peers play a really unique role, is because it's often not the message, it's, who it's coming from. I'm very glad you brought that up.
Okay, so it's 10:58. I think we can keep the webinar going for maybe a few more minutes, if that's okay with you, Colton,
Yeah.
just to catch any last questions. But I think at this point, I want to thank everyone again for attending, and I'm going to echo all the comments that we're seeing in the chat box right now. Thanking you, Colton, for sharing your story, for sharing your personal insight and your professional experience. It sounds like this was just really valuable for everybody. And I'm going to guess you're going to have some people reaching out to you to connect directly after this. So thank you. And thank you to everyone for attending today and for giving us your time in what seems to be a much broader competition of webinars right now.
So it was really great, guys. Thank you for having me. I'm really glad that we could put this Zoom call together, that we could all, connect even with some of the limitations that we're having as a result of COVID. So thank you all for logging on. Thank you, NCADA, for setting this thing up. And, let's continue to push and continue to try to make a difference, guys. Thank you.
So Colton, if you'd like, I can go ahead and share my screen to that initial just slide that was sitting up earlier, if you'd like to do that, or would you like to hang out a little longer?
If we don't have any more questions rolling in, I think we can go back.
I'll do that. And Colton, do you think, would you want to, in the chat box, would you, before we switch the screen, would you want to type in some contact information if people do want to get a hold of you directly? What's the best way to reach you?
Absolutely.
Okay.
I will add that in right now. Thank you all.